This is Tricia Barrett, Vice President, Product Design and Support. We are here today to introduce our 2017 standards for the patient-centered medical home and how those interact with our newly redesigned recognition process. I'm going to talk a little bit about the landscape, what led us to the changes that you will see, give you a bit of insight into what the new requirements, how they look, how they're structured, what they're going to feel like for you, and then we also have a number of panelists that will be joining us to tell you a bit from their perspective about the new requirements. So if we move to the current landscape, I think that these are all probably familiar concepts to you, the idea of the move towards value-based payments, the reward of value, improving quality, and trying to make sure that we are paying for what really matters, and what really matters is the actual outcomes of care. At the same time, there is a move towards patient-centered care that is accessible at the place and time when patients are seeking it, and that has meant a bit of fragmentation in the delivery of care with organizations such as retail clinics and urgent care centers, worksite health clinics, and telemedicine providers all having a place to play within that environment. And so it becomes even more important that we move towards better integration and reduced fragmentation of that care. As payers are looking to reward value and consumers are receiving care from this increasing number of providers, it's imperative that all members of the care team share information and collaborate to optimize those outcomes. More emphasis is being placed on the patient-centered medical home model of care as a solution. This model of whole-person care and coordinated and tracked by the primary care provider is really essential to making sure that patients feel embraced by the health system and not lost within it. The graphic here is showing the medical home neighborhood. There are certainly other players in it, but this is one way of viewing it with a variety of different partners that all interact with the patient in order to provide the best possible care. And as it grows, we continue to see payers wanting to reward value and the outcomes. We go to the next slide. There is a growing body of evidence that shows that the medical home model of care is saving money by reducing hospital and emergency department visits, mitigating health disparities, and improving patient outcomes. One study looked at Medicare spending in NCQA recognized Pcmh practices and found that the total average spend per beneficiary was lower in those NCQA recognized practices. 62% total lower spending was attributed to reductions in payments to acute care hospitals. So the goal of the Pcmh, reducing hospitalizations and ED visits, keeping patients healthier and out of the hospital and lowering those costs does seem to be working. On the next slide, we see another study that demonstrated a lower emergency department use and hospitalizations for adult patients, again, within recognized Pcmh practices, in this case leading to 15% lower costs. And this was in more of a commercial population and private health plan. So it is something that is having an impact on those costs. We do provide additional research summaries and information on our website. There'll be a link to that later into the slides. But, although I emphasize the costs just now, because that has been a big area of focus. We're also seeing those results in patient experience ratings, quality ratings, and even in physician and other practice partners' satisfaction with their work. So getting us to that fourth aim of the triple, and now some people calling quadruple aim, of improving the workforce satisfaction and therefore reducing worker burnout. So let me tell you a little bit about NCQA. If you're not already familiar, you're probably not on this call. So, we have a number of recognition programs in addition to our other programs. I just want to give you a brief overview, though. We are a private nonprofit organization. We look to that landscape to build our programs in a way that will help to address our mission of improving the quality of health care. For those not as familiar, we people need to know where to find good care. So we evaluate health plan and medical practice quality. We create standards, measure performance, and highlight organizations that do well. All this helps to drive improvement, save lives, keep people healthy, and save money. The National Committee for Quality Assurance has over 25 years, I believe it's 27 now, working with payers, health systems, and clinicians to improve that quality of health care. You can see here our seals for several of our recognition programs. These all work together to help transform the delivery system and support an integrated set of providers, all working towards that goal of a patient-centered healthcare system. On this slide, what you see is as of January, so as of the end really of 2016, we have over or close to 12,000 recognized practices. I believe it's over 12,000 at this point. But it has spread across the country, although there are certainly some areas with higher volumes than others. It is something that is widespread and really being well adopted. Overall, approximately 18% or 1 in 6 doctors in the country practicing primary care physicians are in a recognized medical home. We do that count, although we also recognize nurse practitioners and physician assistants that are part of practices or leading practices. We weren't able to get a denominator, so this just allows us to see what sort of penetration there is of patient-centered medical homes out in the community. Before we get into the updated standards, I would like to tell you a little bit about the recognition redesign, the changes that we've made to the process in order to make it more customer-friendly and collaborative in its approach to helping practices get from where they are today to a transformed system. The Redesign program, which is planned to be launched on April 3rd of this year, includes ongoing sustained recognition status with annual check-ins and reporting instead of the current program's 3-year recognition cycle. So why did we redesign the program? First and foremost, the redesign responds to your feedback. Practice staff, clinicians, and certified content experts all recommended many of these changes. They told us to improve the process, to cut back the paperwork, to simplify reporting. They told us they wanted more time to concentrate on care. We also considered the changing payment climate. Recent changes in federal law, including the Medicare Access and CHIP Reauthorization Act of 2015, or Macra, will change payments to reward value-based care. Our redesign process aims to align reporting requirements with those expected Macra changes to eliminate duplication of work. NCQA also worked with numerous organizations that certify clinicians. Now, in many cases, NCQA Pcmh recognition will provide credit toward clinicians' maintenance of certification requirements with their boards. So why are we changing it again? Giving a little more information about that, the kind of feedback that we received included that the current process had too much documentation. There were too many pieces of paper flowing. Although they were virtually flowing, they were still being prepared and put into the system, and it was tedious. Practices wanted more interaction with NCQA, a more dynamic relationship, interactive approach to the evaluation so that things could be explained. Practices could tell their story instead of just trying to provide a communication through our online portal. It was too challenging for some smaller practices. We heard both ends of this argument. Sometimes it's too challenging. People thought that the standards were too easy in other cases, and so we needed to make it something that was flexible for a variety of practice types. And a practice that is operating as a medical home shouldn't have barriers to being recognized as one. We needed less emphasis on process and more on performance. We wanted to tie in clinical and other performance measures to the overall recognition. And while some of these changes will be phased in over time, we have begun to incorporate that performance information into the standards when when you see them. Currently, we have two separate and somewhat complicated tools that are used by practices to go through the recognition process. Our new platform that will be used in this recognition process will integrate those activities, so there'll be just one point of entry into NCQA. And practices should be demonstrating ongoing improvement. This is something that we heard in particular from payers and other stakeholder groups concerned that perhaps practices were looking at the recognition process more as a project to be sort of overcome and done, and then kind of putting it on the shelf instead of a living, breathing model of care that needed to kind of continue on in the interim between the recognition review cycles. So what does the new process look like? So while today our process involves practices learning what they can about the medical home model of care and our standards, learning mostly on their own, perhaps attending education programs. In the future, practices will have an NCQA representative that will help guide the practice through the process and plan out that recognition process. Currently, you submit all of your documentation at once, hoping that perhaps you've provided the right information. In the future, there'll be a gradual submission process where along the way you have the opportunity to get feedback to make sure that you're on track. In addition, much of the documentation that is currently submitted as policies and paper processes and screenshots of your systems will be able to be submitted through a virtual review process. You'll be able to demonstrate what your processes look like, what your systems look like to the reviewer instead of having to do all of that kind of busy work. In fact, a pilot study with some of our recognized of practices that are interested in recognition found on average a new practice cut a third of the time off of the amount of time it took them to get recognized. So that will give you more time to spend with your practice and with your patients. The current survey tool can be cumbersome. The new tool is going to be more intuitive, include tool tips and modules along the way to help you, educational pieces as well. And finally, recognition is currently on a 3-year cycle. This means every 3 years, it's a heavy lift for practices. We'll be moving to an annual check-in, which will allow us to see that the practice has maintained themselves as a medical home in the interim, and also allow the practice not to have to do all of that paperwork every 3 years. All right, so there are 3 parts in the newly designed process. The first step in that is to commit. The practice will complete an online assessment. It will indicate that, yes, they are in fact eligible to participate, and they will then work with an NCQA representative to develop their evaluation schedule. This means that the practice can decide, I want to work on the access content first, or a different practice might choose to begin with their care management program. It's up to the practice. They can decide which features are most important for them and that they're most ready to begin to have reviewed and begin earning credits towards their recognition. There will be new online resources and educational supports in addition to our very popular live trainings as well. Then the practice is moving into their transform stage, where the practice begins to make the changes that are necessary within their organization. They tailor the medical home model to their practice needs, to their practice patients, and they begin the process of submitting documentation to us. That documentation, again, includes some amount of online material submission, but the important part is this virtual check-in with their evaluator, where both parties will be on the line, talking through, viewing, sharing their screen, and earning their credits towards their recognition. We anticipate that there will be 3 such check-ins across the period of time while the practice is transforming until such time that they've earned sufficient credits to earn their recognition. And from there, we expect our practices to succeed. The practice is now prepared for new payment environment and for reporting on an ongoing basis to all those entities out there that are interested in seeing a value-based approach to care and payment. In addition, the practice will, in that phase, be able to submit to us on an annual basis just some minor number of indicators that tell us the practice remains on track. Things haven't slid or changed in significant ways that are harmful to the patients. All right. So the redesign process is going to offer you flexibility. Practices take the path to recognition that suits their strengths and schedule and their goals. Personalized service. Practices get more interaction with NCQA and are assigned an NCQA representative who works with them throughout the recognition process and is a consistent point of contact. There'll be a user-friendly approach. Requirements remain meaningful, but with simplified reporting and less paperwork. There'll be continuous improvement. Annual check-ins help practices strengthen as medical homes over time. By reviewing your progress more often, we hope to keep performance improvement at the top of your priority list. And it all aligns with the changes in healthcare, in the healthcare environment more broadly. We're not going to take time today to get into all of the details of the redesign process, but hopefully this was enough of an overview to help you to see how now, as I launch into the Pcmh 2017 standards, how these will be executed. As we developed the 2017 standards, we wanted to make sure they were built aligned with the goals for improvement. As a refresher for those less familiar with NCQA Pcmh recognition, the first change to the structure of the program is the evolution of what we are calling the requirements. Under the old standards, you were evaluated on standards, elements, and factors, and you had a certain number of requirements at all levels. You had to earn a certain number of points in total. You had to earn a certain number of factors within an element in order to get the points for that element. There were a variety of layers to this. We were really trying to simplify this with the new model. Ultimately, patient-centered medical home is based around a set of concepts about how you should be practicing, how you can best serve your practice. As a result, instead of standards, elements, and factors, the new structure of the program is concepts, competencies, and criteria. Concepts are the overarching themes of what make a medical home, and are really similar to our old standards. The competencies are a way of us organizing and thinking about the criteria. It provides a little bit more depth of the intent of that content area. Where the rubber really meets the road is in the criteria themselves. This is the set of the individual things that you do to help demonstrate that you are operating as a patient-centered medical home. So let's talk this through in a little bit more detail. There are 6 concept areas. You can see them listed on this screen. I'm going to go through them one by one on the following 2 slides, so I won't linger here too long. I'm going to go right on to the next slide. We're team-based care and practice organization. In this section, this concept involves how is the practice organizing itself to deliver on the patient-centered medical home model. We know that it takes resources and supports within the practice, that everyone in the practice needs to be on board in order to deliver that team-based approach. And it's important that the practice really organize itself, have a leader, have individuals know what their responsibilities are, and that you help orient patients to this model of care that, while it doesn't matter what you actually call it, helping patients to understand how you're going to interact with them, what they can expect of you, and what they should expect, what you expect of them in that process is really important. The next is knowing and managing your patients. This is similar to our population health standard and our data collection standards that we've had in the past. We are looking for the practice to have an understanding, conduct an assessment of your patients, collect key pieces of information and assure that evidence-based clinical decision support is put to use for the benefit of your patients. Help to connect patients to those community resources, all essential parts of managing your patients. Patient-centered access and continuity. This remains about making sure that patients can get access to the care and service that they require when they need it, so that they don't have to go to the emergency room or to some other disconnected source of care. They understand how to get their questions answered, whether it's during or after hours, and that there is continuity, that there's a sense of relationship between the practice and the patient. The next concept area, care management and support. This is about identifying your highest risk patients, those that have the most complex needs or complexities in their ability to obtain the care and achieve the health outcomes that they desire as a result of perhaps social determinants or other factors that are impacting their health. And so in here, we expect practices to identify the most at-need patients and then develop a person-centered care plan to support that patient. Care coordination and care transitions remains about the connection of the practice with the rest of the world, making sure that any services that are ordered or sought in conjunction with the care that your patient requires is connected back with the practice and able to be incorporated into that overall plan of care for your patients. And then performance measurement and quality improvement. Of course, we're looking for practices to continue to assess their performance and have a data-driven approach to quality improvement. So with this new process and new standards also comes a new way of thinking about the scoring. So our goal here was to simplify the scoring process. Instead of that embedded layers of standards, elements, factors, must pass, critical factors, et cetera, that some of you are familiar with. Our goal is really to make sure that the focus is on what makes you a medical home and how can you tailor it to the particular needs of your population. In order to get recognized, you have to complete all of the core criteria. Those core criteria are the things considered just foundational. This is what makes a medical home a medical home. And then you will have the opportunity to select among the many available credits for elective criteria. You're going to need to earn 25 credits of the elective criteria. Sometimes the electives are worth more than others. We have two levels of criteria that are elective, worth 1 credit or 2 credits, depending on the intensity of the requirement. You can piece these together any way you want, but there is one requirement, which is that at least 1 credit needs to be earned in 5 of the 6 concept areas that I outlined before. But this just gives the practice the opportunity to say what really matters to their patients, to their population, what capabilities do they have, what resources do they have within their community, and to shape the program the way that makes sense for them. Here on this slide, I'm going to provide you a quick example of how this all fits together, what you're going to see, what things look like. So in this case, we've got patient-centered access and continuity. It's one of our 6 concept areas that we've already discussed. There's more than one competency in this particular concept area, and here you see the first of those. This is the Pcmh model, seeks to enhance access by providing appointments and clinical advice based on the patient's needs. In addition to being key to patient-centeredness, evidence explicitly supports that providing enhanced access, including same-day extended hours and telephone advice from clinicians with access to the patient record, reduces those ED and hospitalizations. So you can see we've tried to outline what is it that we're trying to accomplish with this set of criteria. And then there are, as you see here, 5 core criteria that have been outlined and 4 elective criteria. So you will need to meet all of those core criteria. These should all look pretty familiar to you if you're familiar with NCQA's program from before. And then you have the option of the elective criteria. All right. So as I've already mentioned, we've eliminated the scoring, or we've eliminated the points structure that we've had in the past, and we've identified that there are these core requirements, the core criteria, and then 25 credits of elective criteria that will be needed to earn you your recognition as a patient-centered medical home. So in the past, the scores is what made a determination between level 1, 2, and 3. We will not have those scores any longer, and therefore there'll be a single level of recognition. You are either operating as a medical home or you're perhaps on your pathway to it. So we will begin to release information about practices that are in the process. So you've committed to recognition, you've begun to earn your credits, and to us that's really similar to the old rule of having at least a level 1 recognition. But we did this in part because of the research studies indicating that there was such mixed results depending on the level of recognition achieved. And we think that it's time that the model is mature enough at this point to be able to say distinctly, this is a medical home practice and this is one that's not quite there yet. So the new standards, we believe, will help to improve the focus and the flexibility. We've reduced the total criteria that are included. There were previously 167 factors in the 2014, and currently there are 100 criteria, again, with only 40 of those being absolutely required. Core and elective approach allows practices to tailor your program to your population, and we've eliminated a number of more detailed structural requirements that were embedded in those old factors in favor of more outcome or results-oriented requirements. It supports your continuous practice transformation, includes the activities necessary to achieve our stated aims of the triple aim and to drive that improvement that we're looking for. It focuses on whether the intent was achieved and the care was improved rather than on whether a box was checked. It updates the documentation methods. We haven't talked a lot about how much less documentation the new process will require. Previously, all proof had to be submitted through sort of paper or electronic documentation. Now that screen sharing and virtual review process will be part of that recognition process, and so it will make it a lot easier for you to go through and just demonstrate how you are operating as a medical home. It helps to accommodate a spectrum of practices with varying levels of sophistication and complexity, and it allows a variety of response options that demonstrate a requirement is met. It emphasizes comprehensive integrated care. Understanding the behavioral needs and social determinants are included in our core requirements. These were always present in the program, but they are now a portion of the core. And there's deeper integration and community connections included in the electives, allowing for, again, that tailoring to the community that you're serving. So before we get to our panel, I'd like to let you know a few resources available to you. First, if you have any questions, you can submit them through the My NCQA portal at my.ncqa.org, and an NCQA representative will be available to answer your questions. The standards will be released on April 3rd, but all of you will receive an email in the near future with an overview summary of the standards. So that's our preview copy. It will give you the first look at the details of the requirements. Our first education session that's going to cover the 2017, the live education session, will be on May 16th and 17th in Baltimore, and the registration is open on NCQA's website. You can get more information on the redesign of the recognition process at ncqa.org/redesign. And if you are a practice that is not currently recognized but is considering recognition, you can visit www.ncqa.org www.ncqA.org/PCMH-info for more information and to contact NCQA representative. All right. So now I would like to introduce our panelists. We have 4 panelists joining us today. We had the pleasure of working with each of them during the development process for the 2017 program. I'm going to start with Dr. Yul Edgeness. Yul is a board-certified internal medicine physician and co-founder of Coastal Medical, Rhode Island's largest primary care practice and a Level 3 patient-centered medical home, and a Medicare accountable care organization. So when he's not busy doing that, in addition to practicing full-time, he's a clinical associate professor of medicine at the Warren Alpert Medical School of Brown University. He's a member of the American College of Physicians delegation to the American Medical Association House of Delegates and serves on ACP's Coding and Payment Policy Committee. He began in 2014, began a 3-year term on the American Board of Internal Medicine's Internal Medicine Specialty Board. Yul, what can you share with, in addition, he was the chair of our advisory committee that helped us to develop the 2017 standards and part of why we asked him to join us here today. So Yul, what can you share with us about what the PCMH requirements mean for the medical home model and for you?
Yeah, so I was thinking about this, and I've actually crossed paths in my career 3 times with the PCMH recognition program. 10 years ago, I was involved with the American College of Physicians leadership, and the ACP had published the Advanced Medical Home White Paper, which was one of a series that eventually led to forming what we now know as the Patient-Centered Primary Care Collaborative and the Medical Home Joint Principles. And so in that situation, I was involved with giving feedback to our representative to NCQA that was putting together the first set of criteria for recognition. And it was an exciting time because nobody was doing this, and we were looking to provide guidance to our members who wanted to try it, as well as to make it a credible model so that a practice could say that, yes, we are a medical home, we can do this, and actually be able to back it up in some way, which would be helpful for patients trying to select the practice and to payers looking to pilot this. So then, fast forward to 5 years later, and my practice, which is at that time was probably about a 60 or 70 physician practice, decided that it wanted to go for recognition. So all the discussion of transformation and the theories behind it from 5 years earlier became reality in my day-to-day existence, and we used the recognition program as a way of showing us what we needed to do if we weren't already doing it. And it was quite a grueling may not be the right word, but very intense activity where we had outside consultants who were expert in this help to guide us. But we were successful and have been a medical home ever since. I think we were a Level 3 recognized home from the get-go. So then, fast forwarding 5 years later, and here I am asked to be a member of the advisory committee to develop the 2017 program, and certainly 5 years later, the question becomes, how relevant is the recognition program to a practice that's already been doing this and succeeding in it? And as you mentioned, we're a Medicare Shared Savings Program, ACO, and have done very well there as well. So if you need to be recognized in order to prove that you can do it, once you're doing it, why do you need to prove it, being the question. The other perspective that I brought into this was hearing from colleagues, including my own personal physician who is in a small practice of 4 or 5, and how difficult it is for them to keep up with the program, as well as even within my organization, just the administrative burden of getting in the recognition program. So I was very happy to be part of this process on the advisory committee. I remember a comment I made in the first phone call we had was that I thought the process was in many ways like holding tryouts for the track team, but instead of qualifying members of the team based on how fast they ran, also asking them to prove that they knew how to walk and how to tie their shoes. And some of the elements in the old program really looked like that. And so I was very happy to see that we were focusing more on outcomes and results as opposed to process. The other areas that were meaningful to me in this new revision are that the core and element concept, recognizing that an advanced medical home can do a lot of these core elements and some of the elective criteria, but maybe not all of them. And this almost sets out a roadmap for things that folks who are very, very savvy in the model spelled out as aspirational goals that they can then strive for, rather than becoming complacent and saying, "Well, we've done it, and now what?" And the recognition also that every practice environment is different in terms of what resources it has. And we talked a lot in the advisory committee about health information technology, interoperability, and how it varies from place to place. So some of the criteria needed to take that into account. Similarly, how accessible behavioral health was in terms of some of the models looking at co-location and referrals. So I think the way the structure of the new program is set out with the electives and requirements that allow you to tailor your program to what's available in your area is a very positive change. Lastly, I just wanted to point out, and we have another member of the advisory committee on the panel, but this was quite an interesting group. I mean, it was very diverse. NCQA assembled clinicians from small and big practices, rural, suburban, urban, folks from the payer community, from the organizations, health policy experts, and patients. So it was a very diverse group that gave us a very rich discussion, and I think the results show in the program that is going to be unveiled. So, I'm as a practicing doc, I'm very excited about this. I think the person in my practice who is in charge of keeping us recognized by NCQA is also very pleased with what's coming down the pike, and I look forward to seeing how it all plays out. And thank NCQA for letting me be part of it.
We got 2,100 registrants.
Thank you so much. I'm going to turn now to Deborah Johnson-Ingram. Deborah is the Director of Healthcare Compliance and Patient-Centered Services at the Primary Care Development Corporation. Prior to joining PCDC, she worked for IPRO, the New York State Quality Improvement Organization, as a Senior Clinical Practice Advisor. She is a Pcmh CCE for NCQA who has experience in facilitating the implementation of electronic health records and practice transformation. And she has consulted for a variety of accreditation programs, healthcare organizations, including hospital, outpatient departments, FQHCs, and private practices. So, Deborah, can you tell us a bit about how you think the new standards are going to help you work with your practices to transform?
So our partners here at PCDC, our partners in health, we call them, I think the new standards and process can help our clients continuously improve and sustain transformation. I think the standards would help them, provide that framework for them to shoot for the next level of their journey towards patient-centered excellence. And for our future partners in health, the new process will allow them to adopt the medical home concepts more organically and over time, where the process will put more emphasis on the transformation and not so much on perhaps the documentation to prove it. One specific area that we are excited about here at PCDC is the concept statement, knowing and managing your patients. And in particular, it's the analytical component. So as being one of the folks who was a participant in the revision and of the new standards, I got to know a little bit about both the core requirements and some of the new criteria, the elective criteria. And I noticed that some of the concepts that we'll be focusing on basically the namesake of the program, so it's all about the patients, specifically in, this area. So it's all about the patients and the practices and the community that they serve. So now the practices have to make sure they know and understand their community in order to provide them the best care that's possible. So while the PCMH statement contains remnants of the 2014 Population Health Management Standards as its core criteria, it includes really some real dynamic elective criteria that will push our partners to do more. PCDC has extensive history with supporting Medicaid providers, and this section is an area where they can highlight their advanced knowledge of assessing, addressing the needs of a marginalized safety net community. So we are really excited to see that and making sure that we push and, be a champion for our practices that are trying to go to the next level for 2017.
Great. Thank you so much, Deborah. All right, next I have Dr. Suzanne Berman. She's a pediatrician. She is the co-founder and managing partner of Plateau Pediatrics, the first NCQA-certified Level 3 Pcmh in Tennessee. She serves the American Academy of Pediatrics in a variety of roles, including the Executive Committee of the Section on Administration and Practice Management and the Committee for Child Health Financing. Dr. Berman frequently contributes to AAP projects and publications regarding medical home practice transformation, rural health, coding, data mining, and policymaking. A pretty diverse set of topics there. Suzanne, can you describe some of the special topics in the new Pcmh 2017 standards and how it addresses and supports pediatric practices?
Right. Thank you for the introduction. So one of the sort of beefs, if you will, that some pediatricians have had about the NCQA process thus far is it didn't seem maybe super friendly for pediatricians, or maybe it was achievable, but there seemed to be a lot more difficulty in getting some of the necessary data or reports. For example, some of the sort of previous incarnations were Medicare-centric, and I think my practice of 5,000-6,000 patients has 2 Medicare patients, and so PQRS alignment doesn't really help us. And so I think sometimes it was kind of like, being a vegan, being invited to the barbecue. It's, is there anything here on the buffet that I can eat? Maybe the corn on the cob. But I'm just delighted to say that the new 2017 model, as you'll alluded to, has a lot more flexibility in terms of ways to get to yes. There are some very nice pediatric-specific items you can do now, like oral health, both just an education component as well as a service delivery component. That's something that is sort of an emerging thing that lots of pediatricians are starting to do as part of their comprehensive whole child care. Another thing that is new, that's pretty exciting for us pediatric folks, is credit for school interactions. A lot of my colleagues are part of their medical neighborhood by serving as a school physician, and now there's a way to document that and get credit for all the ways that helps not just the patients in your panel, but the sort of school health community, since a lot of kids do get some health services delivered through school. And it doesn't even have to be anything that formal, like our practice has a protocol for providing EpiPens to our county schools, and that would be, how the element is written. Something even as simple as that would qualify as a, sort of school interactive support for that. Something else you'll alluded to, there is now, I think, really a true emphasis on quality and not just process. Now there are several places where you can get credit for adopting evidence-based clinical protocols for labs and x-rays and referrals. It sort of used to be, if you treat, for example, right now is RSV season in the pediatric world, which is can be pretty serious disease. It's certainly very common, and it doesn't obviously respond to antibiotics or steroids, but you could sort of, under the old model, you could say, I give the right dose of steroids every time and a safe dose of antibiotics, but that's not really evidence-based care because the evidence shows those things don't work and can even be harmful. So now you can get credit for saying, I only order x-rays on kids with RSV when there's a clinical indication for it following the national evidence-based standards. I for asthma referrals, when do I refer for asthma while using the NHLBI standards? I refer, for allergy testing or pulmonary function testing if I can't do it in my office. I think there's some other sort of positive changes that are going on. I think there is some of the meaningful use elements are being sunsetted, which is, I think, the right choice, given that many of us are sort of in our final years of meaningful use alignment, and so continuing to get those specialty reports from our vendors at sometimes a significant additional expense. This is going to be a nice change for those of us in the pediatric world.
Wonderful. Thank you so much for sharing your perspective. Finally, we have Kerry Miller. Kerry is a Pcmh CCE who's worked with private practices, integrated healthcare delivery systems, hospitals, health plans, federally qualified health systems, residency programs, and many others on their recognition process and practice transformation projects. She currently managed the value-based programs for Horizon Blue Cross Blue Shield of New Jersey. She oversaw the implementation of Comprehensive Primary Care Initiative for CMS, and she has served as the Director of Healthcare Transformation for a state provider association, as well as a director with the New Jersey Medicare Quality Improvement Organization for over 10 years. Kerry, can you tell us how the recognition program process might help your practices in your work?
Sure. Thanks, Tricia. What I originally had started to do when NCQA asked if I could provide some information was I kind of came up with a top 7 list and then realized I had about 5 or 6 minutes to talk, so I quickly dwindled that down to a kind of top 3 list on ways that the redesign process really is going to help practices enhance what they're doing as NCQA enhances the overall process. So I'm going to kind of start with number 3 and work my way to the number 1 reason I typically hear what practices are saying and how NCQA has been responsive to that with the new redesign process. So number 3, often what I was hearing from practices and others that we worked with were the standards were really difficult, and sometimes they needed interpretation and they were hard to understand. So they would ask, can't these be made easier for us? At times they felt that they needed more of an interpreter to help them kind of get through the NCQA standards, and they wanted a place that maybe, you could direct them or we could direct them for resources. So I think with those types of concerns and the redesign process with the rewrite of the new standards, these have been addressed. NCQA has been very responsive to that feedback from practices and Pcmh CCEers. They have developed a real easy-to-use electronic format for those that want more of the technology component and be able to get online and have quick links to be able to see things and move quickly through the standards. But they also have maintained a version that can be printed and used by practices who are much more comfortable looking at them online, printing them out, and then carrying them to all the meetings with them so that the coffee stains and the earmarked pages are still there. So NCQA has really adapted the standards to meet those who prefer the electronic version while also really maintaining the version for those folks who still want that hard copy and need to touch it and see it and put it in a binder and carry it around with them. So I think the number 2 concern that we would hear from practices that has been addressed by the redesign process is practices would ask if the Pcmh work for recognition could really be, more aligned with the work that was really currently going on in the practices because of all the competing priorities. It wasn't that the Pcmh standards in the past weren't aligned with transformation. It was just that at times practices might be focusing on specific areas and maybe not the whole broad spectrum. Okay, so I think with, as others have said and as was introduced by NCQA, with the new redesign process, it's going to allow practices to select from elective components that the practice then could much more closely align with the works that are going on in the practice and what the practice themselves have really identified as specific priorities within the practice. So while there are still some core components that absolutely have much relevancy around the fundamentals, as we were talking about earlier, of the transformation work. The elective, having the flexibility to select elective components will really help more better align for the practice's perspective with the transformation work and other quality initiatives and other work being done and completed by the practice, so they don't feel like they have to be pulled in all these different directions for priorities. NCQA has really taken that into consideration, and with the elective and core components, I think has really addressed that. And I think, you know, as much as if anybody out there is a, Big Bang Theory TV show fan, as I am, I love the Big Bang Theory, but the Big Bang Theory is not necessarily the best approach at times. And I think with the way that a lot of practices kind of went all or nothing, they would go gung-ho for, when the recognition period was coming up and they had to re-renew. And then at times throughout that lag of the 3 years, they might let some things slide due to other priorities and other work going on. So I think as NCQA has moved the process to a more annual ongoing process, that's really going to help practices not feel that they're kind of having to go big bang on this and spend all this focus and get this all done up front. They'll be able to schedule better, have more flexibility, and really know what's coming on a regular basis. So that was my number 2 concern that I think I heard from a lot of practices, and I'd say I'd be surprised if many of you were not going to be surprised with the number 1 component on my list that I've heard from many practices and those that I've worked with is practices would often say that they really didn't have the in-house expertise to, develop all these text boxes and arrows and screenshots, and they would spend a lot of time having to change formats and the way things looked to make sure it was fitting into the way that they perceived NCQA wanted to see it. And we also heard that a lot of times, EHRs really didn't generate the reports, and they'd have to maneuver things or move things around or hide things or disguise things. So I think that is the overall number 1 concern or concerns I've heard from a lot of practices. And again, I really think NCQA has taken all of those issues and concerns into consideration with the new Redesign process, because with the virtual review component, it's going to make it a much smoother and easier process for the practices, because you will be able to, as Tricia was saying, show NCQA not so much what your process is, but really what your outcome is. The redesign is really much more focused on outcomes, and you're really going to be able to show how you get it done, not so much, and what it is that you're doing, and not so much time spent on collecting all the materials, collecting all the documentation, putting it all together, coming up with a file structure. You're really going to be able to go through it in real time with your NCQA manager. So I think that really addresses a lot of the number 1 issue that I typically hear from a lot of practices. And I would say, kind of on a side note, for my colleagues out there that are also PCMH CCEs, I think there's been some kind of conversation about, well, with the NCQA manager, is that really going to take over the role of what a PCMH CCE was doing on behalf of the practices? And I would say I think PCMH CCE professionals are still going to play a critical and pivotal role in assisting the practices through the transformation and recognition process. Because I think the opportunities for these professionals is really to continue to work with the practices. They're going to be able to help the practices identify, what elective elements might the practice consider for submission. They'll still be able to assist and help with the interpretation, assessing, and reviewing of the practice's documentation, and then fine-tuning that through a transformation process if it does, in fact, need to be fine-tuned, along with, the work processes, the workflows. Really to help practices ensure that they're not only meeting, but really exceeding the intent of the core and selected elements. And I think possibly from my perspective, what the PCMH CCEers really bring to the practices as extremely valuable component that they really can't get otherwise is PCMH CCE people, professionals, really have that lessons learned and best practices that they can share and spread through the various practices to really facilitate the transformation and recognition process. So practices really, as you all know, you operate within your 4 walls, and PCMH CCEers really still have, maybe even more so, the opportunity to share, what is and what is not working on a more broad perspective in primary care practices. And I really think that's going to enhance the learning opportunities for practices who are, in the process and on the long-term journey to be innovative and responsive to really what we see as the ever-evolving and often challenging and constantly changing landscape that we're all working in.
Thank you so much, Kerry. So we had quite a few questions that were related to the role of the Pcmh CCEs and what their role will be in the new process. And gratefully, Kerry has already answered that. We're really looking forward to continuing our work with our certified content experts that are on the ground supporting practices through their changes in their practice, and really recognition becomes a byproduct of the effective transformation taking place. And yes, we also have an ability for CCEs or other consultants that are working with practices for the practice to set you up as a user on the new platform. So you will be able to interact with NCQA right alongside your practice. In addition, you'll, in a future version of that platform, be able to see a dashboard across all of the practices that you're helping move through the process, whether you're working within a single health system or across many different health systems. You'll have an ability to sort of look inside to the status of their process within the system. How long does it take to complete the recognition, that transformation phase that I described with the 3 check-ins, and is there a minimum or a maximum period of time that is allowed? We anticipate that practices will enroll when they're ready to start that transformation. So they should have a good understanding of what it's going to entail for them as a practice, but they don't have to have everything in place and ready to go. You'll then make sure that you've really understood those standards and are begin to do that transformation. It's really going to depend on where you are. So a practice that is already has care management procedures in place and perhaps an access process, a variety of the features of a medical home, but maybe not all of them, might take only a few months or 6 months or something. Others we think will take perhaps a year to go through it. We do the price that we've set. There were some questions in here about the pricing. We have all of the pricing up on our website. It's more involved than something I can just say it's X dollars, because it depends on the number of clinicians in your practice. It's important to know that it is a single upfront fee, and then there's an annual fee. No longer will there be an every 3-year process. You won't have to get kind of reviewed and renewed in your recognition every 3 years. So that was another set of the questions. If you go to ncqa.org/redesign, that's where you'll find links to information about the pricing, about all of these process changes that I've described, and then another slew of questions were related to I'm currently recognized and I'm this type of recognition, this level, and what should I be doing next? We have some clear links that describe if you're this type of practice, click here and it will tell you about what your options are for getting up and running on the new platform, the new system, the new model of recognition. So I think I answered that question. And that one, is the new process supported by federal government program previously known as GRIP? So we continue to have our GRIP, or government recognition programs unit, and they will begin using the new process with the next contract year for that particular set of work with FQHCs and the like, and that is October 1st of 2017 is when they'll begin to use the new process. I mentioned the pricing. There's a quick question of, will NCQA sign BAAs or business associate agreements related to HIPAA compliance with the practices for the virtual session? Yes, we currently hold business associate agreements with each practice already, but yes, that will continue to be the case, and we'll make sure that we are using secure systems for purposes and not unduly accessing patient-protected information. All right, this is a difficult question for me to answer, and I don't know if any of our panelists might have something to say on this, but does NCQA have an idea of when payers and state programs that may tier their reimbursement to practices based on PCMH levels will change their reimbursement structure? We have been making sure that we are communicating with all of the health plans that we know of, and states and other incentive programs that are out there that are relying on NCQA recognition, so that they understood what changes were coming. We didn't move lightly to the decision of eliminating the levels, and we were supported in that decision in working with the payers. They actually, there were a number of these changes that I've described today that really were driven by the needs and desires of the payer community. So we don't know what their timing will be. We've again tried to be clear about when, how this change is going to be happening, what the timing of when we would be releasing things, and when we would expect to start actually recognizing practices under this 2017 model. As I've described, you sign up at the beginning, and so it'll actually be a period of time before practices will be recognized under the 2017 model. So there is still opportunity, and we didn't want certainly practices to lose any of the credits that they're earning already by virtue of being a recognized practice in our current level system.
This is Suzanne Berman. Just to supplement what you said, Tricia.
Thank you.
Some payers are already changing their published documents, so they're already sort of mobilizing their resources to address this issue. Obviously, we know some payers are faster at implementing changes than others. I can tell you, just in my state of Tennessee, where there's a pay for recognition program, how they've sort of rewritten their documents are, you have to be level 2 or 3 if you are recognized in a model that has levels, or in the future system, you just have to be recognized, is how they've sort of tweaked their requirement.
Great. All right. I was just pausing to see if anyone else wanted to chime in. Somebody handed me a note that if you have questions about a specific payer, we do have a resource list on our my.ncqa.org on our website, providing information about payers that have incentive programs associated with getting recognition. Here's a question. Okay, so I had a question for Dr. Edgeness and Dr. Berman. What's the best method for nurses and other staff to really buy in the importance of PCMH in a busy practice? It is one thing to do your job, but another to enjoy and embrace this model.
Yeah, that's an interesting question.
Yeah, it's a deep one.
Certainly some of it, I guess, you take on faith, since you can't show it until you've done it. But part of the team-based model that is at the heart of the PCMH is having people do work that's at the level of their training and license and whatever other background they have, so that you have medical assistants doing things that they actually went to school to do, and not just putting people in rooms. You have physician's assistants and NPs doing clinician level stuff and not administrative or clerical stuff, et cetera, et cetera. So I mean, and you can show that. Certainly there are a lot of case examples of offices that have transformed where it's not just the folks signing the paychecks who are happier, but the frontline staff, the receptionists who are, because they see more meaning in what they're doing, and having patients actually tell the practice how they feel, and hopefully having it be positive does reinforce that. I mean, the other area, and I mean, this is an example from our own practices, practicing in this model does tie into payment, and we have generated savings and surpluses for insurance companies, and we share that with our staff as we do with the clinicians who provide the care in the exam room. So that's another example of what's in it for them.
Yeah, this is Suzanne. So getting your staff to buy into the model, I think, first of all, if I had an answer for that, I would sell it on eBay, and I'd be a billionaire, because I would do consulting full time. But I think humans are always, we would much rather use carrots than sticks. And so generally how I approach it is, how will these changes make life better or easier for my staff? I think many of our individual contributors, really not just in medical practice, but in any organization, think, okay, another change I have to learn, change is bad, dig in my heels. I think we need to, first of all, recognize that when we say change, improvement, some people are afraid they're going to be changed and improved right out of a job. And so I think you have to start by saying, I value you, but I want you to learn more and better. Healthcare any business changes and expands 5 to 7% a year. So just to keep up, all of your staff have to improve 5 to 7% every year, and then to really get ahead of the game, they have to do more than that. So that's sort of the stick. But the carrot is, I think you can show people, and it's a process, it's not a overnight magic wand, that transformation makes their jobs easier. Like when you go from a pre-booked schedule to where you have no openings for 6 months to an open access schedule, your receptionist or whoever does your scheduling loves it, because they don't have to argue on the phone, oh, no, we can't fit you in for 6 months, and our only appointment at that time is, at this problem. They just spend less time on the phone because, yep, we got a 9 a.m., a 10 a.m., an 11 a.m., and so that the transition can be painful, but once you're there, it's so much easier. Or like moving to a huddle model. Okay, yeah, we all got to get there, 10 minutes earlier or whatever, but there's not going to be any yelling down the hall, hey, can you bring me the whatever it is, because you're going to know that when, Bobby Jones comes in and he's going to be in room 6 today, we're going to need the Framitz, whatever it is, in that room. So they feel like they're empowered to act. When you have a planned QI meeting to talk about this or that, if someone makes a mistake, you can sort of bring it up in that context in a very maybe more of a gentle setting, as opposed to, unfortunately, I've seen, yelling or cursing at someone, hey, I can't believe you messed this up for the 6th time this week in front of patients. That's a real morale killer right there. So I think if you can show people, hey, these changes are not just from the top down, these are to make you enjoy your job more, I think that is going to get people to at least give you a try.
Terrific. Thank you for that. Next question was related to how does the program, the Pcmh 2017, relate to Macra? How is it aligned? The really good news is that the 15% of the score that practices need to achieve in the MIPS side. I'm using acronyms, but if you're the one that asked this question, you probably know why I'm using what these terms mean. We'll be coming out with a series of information about Macra and the relationship between NCQA's programs and Macra and how you can best meet the requirements. But in a nutshell, there's 15% of the credit for MIPS is found in the improvement activities, and you receive the full 15% if you're a recognized practice. In addition, there are the alignment is quite close to the overall aims of the total MIPS and Macra program, and it's we believe, and we've seen in the literature, that you will be on the path to achieving those clinical quality improvement measures, that you'll have better scores in the advancing care information, because although we have not been as heavy-handed, maybe not the right term, but we haven't directly integrated every single meaningful use criteria, which is now known as the advancing care information. The foundation is still there, and so many of the requirements do anticipate that you're using some kind of supportive system in order to perform the activities. We aren't prescriptive about what kind of system that is, but the activities themselves, or the functionality that we're looking for, is still something that's there. And then the cost measures as well, as I described at the beginning. There's been numerous studies showing that transformation to this type of model will have the desired impacts on those cost things. So we believe quite nicely aligned. There was a question about whether what happens to our other recognition programs. So the Patient-Centered Specialty Practice program, for example, was the one that a bunch of people asked about. And will it be redesigned in a similar way? Yes, the answer is yes. We would anticipate, we wanted to get the Pcmh up and running. We need make sure that the platform and all the systems and processes are working well, and we will be taking this next couple of months to a year to sort through the patient-centered specialty practice requirements in a similar way to what we've done with the Pcmh, to divide them into core and elective criteria, and then be able to build those out in the new platform so that the same process can be followed. There were some questions regarding pre-validation and the ability to get credit based on capabilities that the vendors that you might use, be they electronic health record vendors or other service providers. Yes, we anticipate continuing to have the pre-validation program. There is already a crosswalk being built that will identify how credits that vendors currently have earned under the pre-validation program and are able to then convey to their practices that are using it, will be able to, what the credits will be under the new program, exactly which criteria those credits map to. In addition, we will then put out opportunities for vendors to obtain additional credits based on the new criteria that we have in place. And also nice feature is that in the platform, we envision being able to automatically populate some of this information. So at the front end, the practice will be able to say, I am using the following electronic health record, and with just a few easy steps, be able to then mark off all of the items that that vendor is able to provide you credit for. So we'll have a more integrated and simpler use system that will be able to convey those credits. There was also a question about corporate surveys and sort of the process of a multi-site. If you share systems or processes and so forth, how that will work. And in a similar way, we are going to have a much more interactive and dynamic system to be able to evaluate at the level that's most appropriate. We will still be granting recognition at the individual practice site level. That remains the approach that we take. But you won't be buying 27 tools in order to be able to populate it once for your corporate entity and then push all those answers over to your other sites. The sites will all be dynamically linked, and you will have criteria groups that you can share, and you can if you all have the same EHR or the same set of processes for access, you'll be able to mark that once, and it's reviewed once, and the credit is just automatically available there for all of the sites that share that criteria area. There will still be some items that require demonstration at the individual practice site level, and those will be made clear in the materials, but they're a limited number. There was a question of whether 2017 will include must-pass or critical factors, or has that been eliminated? Still, the concept of must-pass remains in that there will be these core criteria. We're providing a lot of flexibility in how a practice actually goes about meeting those core criteria, but those are really the foundational principles of being a medical home, and those functions need to be in place. And then there's the elective credits with quite a few available to you, and 25 needing to be earned in order to achieve recognition. So what is the first date that you can submit for recognition under 2017? It's not the same kind of hit the button once and submit as the 2014 and prior versions, but after April 3rd, you can sign up, you can enroll in the program and begin your process and begin to go through the review process. A couple of questions that related to, I'm currently working on the 2014. Should I, proceed, et cetera? Again, there's information on our website that talks about this transition period, tells you what you need to do. There was a question that related to, do you need to be 2014 in order to move into the annual process? And the answer to that is yes. And we have mechanisms for practices that are not currently a level 3 2014 practice to upgrade themselves or kind of convert over to that level of performance, and then from there they move straight into the annual submission process, the sustaining model. So that's some of the information there, but again, there's a bunch more information on our website that would help you to kind of dissect what makes sense. I think that what we're trying to convey as well, the new process is going to be really does answer many of the questions or many of the concerns that customers had over time. The foundation of what makes you a medical home hasn't changed. We think that the new program, and hopefully you took away from the panelists' comments, the new platform and the new set of requirements, the way that they're laid out, gives you an increased level of flexibility to meet those the way that makes sense, and a new way to do that demonstration that is more organic, more part of your transformation than special work that's done in order to get recognition. And so we're very excited to share this new model and approach with you, but we certainly do understand that there will be some practices that are really right in the middle of their work to transform, and the 2014 is what they're ready to submit under, and so we will have those lines still open through, I believe it's the end of September of this year, with there's a caveat for New York, but that's what we can go into that with those practices that are relevant, and you've already received those communications. So anyway, I think that covers many of the questions that I have had, but let's see if my panelists have anything that got sparked. Nope. There's a really good question about the sort of changing winds of the political environment. Being here in D.C., we certainly are feeling those winds. I think how we're viewing this and everything that we have heard is that Macra was really passed with a strong bipartisan support. And so despite the change in administration and the party that is in the lead administration, Macra itself was bipartisan, and the idea of value-based care seems to be embraced by both sides. We hear consistently from both sides of the aisle about patient-centeredness and the importance of people getting what they need. And so we believe that the medical home and more specifically the move to value-based payment is one that will continue. We, of course, don't have crystal balls and can't be certain of all the changes that will be coming, but we do believe that this is one that will stand the test of time. So we're nearing the end of time. I want to just quickly answer. There was one other question I didn't get to about the annual review process. I think really important, we do already have, again, up on our website on the redesign page, information about what the annual submission looks like, what the requirements are. But in essence, if you are maintaining your operation as a medical home from the time that you were recognized initially till now, you should be in a very good place to easily be able to submit the couple of key pieces of information we ask for in that sustaining process. And so you'll see what those particular items are. We don't yet have the platform up and live, so you can't see where you're going to actually submit it, but we'll be providing that information as soon as the system goes live again on April 3rd. So I think with that, I am going to thank, we had over 1,000 people join us today. We're delighted to have you all there. For those with any technical difficulties, we apologize for that. This has been recorded and will be posted. We'll be releasing that recording, the slides, and the preview version of the Pcmh 2017 content for everyone, I believe, end of this week or early next week. So be watching for that. I very much want to thank all of our panelists, Dr. Edgeness, Deborah Ingram, Dr. Berman, and Kerry Miller for their time today and for sharing their experiences. So thank you very much.